So today's presentation is on delirium. And let me see if I can get this to move. Sorry, there we go. And this is sponsored by, well, UND Geriatrics and the Center for Rural Health and the ECHO program, but also ultimately through the Dakota Geriatrics program, which we call the Dakota GWEP, which is a HRSA-funded program that helps support programs like this. And this is an ECHO format. And so for those who may be new and have not participated in ECHO before, its motto is all teach, all learn. So we really look for feedback from people who have had some experiences with the topic and can reflect on that and provide some feedback. And then we also have a case report as part of this process, to sort of be an icebreaker to launch a discussion. So the goals today are to look at the different types of delirium, look at the risk factors that might lead to delirium, understand what the impact is on patient outcomes, and then ultimately, how do we assess delirium? How do we know it exists? And I'm going to hopefully convince you that a lot of healthcare providers underdiagnose delirium, and that there are ways to both prevent and then to hopefully optimally manage delirium when it occurs. So the DSM-5 is more or less the latest say on how these conditions, all mental health conditions, are classified. So delirium is considered a disorder of attention, and I want to emphasize loss of attention as part of the diagnosis. Other people will refer to it as acute brain failure. This emphasizes the fact that delirium is a somewhat sudden onset, and it tends to fluctuate. However, there are types of delirium that persist for weeks to months, and some use the description of attenuated delirium. Others will say subacute delirium or chronic delirium. But the point is that it's persistent delirium is what we're talking about. So actually, to refer to our pretest question, there's three types of delirium. It's hypoactive, hyper, and then mixed. And if you have a mixed situation, you can cycle through different phases of hypoactive or hyperactive, and one phase may be longer than the other. There's no prediction or predictability of so there's not like equal, you're hypoactive, for X number of hours, and then you become hyper, for another equivalent number of hours. We don't know that. Again, delirium tends to be underdiagnosed. I will show you some data that supports that. And the good news is that a lot of delirium, particularly in the hospital setting, is preventable, and it's reversible. So we're going to go through and try to understand how we can both prevent and then try to reverse delirium once it occurs. So you might ask, it's like one of my patient family members said, what the heck? What causes this? And it's multifactorial is the answer. The two leading thoughts, and we've recognized delirium for decades, but we still have not gotten a medical understanding of whether it's strictly a cholinergic deficiency, so that the cholinergic system doesn't work so well. I mean, that's the same thing that they think Alzheimer's is based on. Or is it acute inflammation? And evidence in some studies show that there's these elevated inflammatory proteins and markers, such as the TNF or tumor necrosis factor. C-reactive protein is commonly tested as an inflammatory marker for rheumatic diseases. And then also IL-1 and IL-6. Those two last factors, IL-1 and IL-6, tend to be elevated in older adults that have frailty. So about 10 to 15% of the population already has elevated levels of these inflammatory markers. So again, the significance of which we don't really understand. The risk factors clearly are related to age, medical complexity, so multiple chronic conditions, and 85 to 88% of older adults have at least one medical condition. 2/3 have two or more chronic conditions. So 2/3 of the older adult population, in addition to age, are at risk. Very clearly, cognitive impairment and dementia are a risk factor with at least twofold greater risk of delirium when you have memory disorders. If you have a functional impairment, so if you have a gait or mobility problem, an activity of daily living that has a deficit or needs partial assistance, that's also a risk factor. End of life, up to, I believe, 85% if more of people who are in their final stage of life will experience delirium. And of course, hospitalization and unsafe medications can be a risk factor for delirium. And we always emphasize the fact that when people take Tylenol PM, and we ask it all the time in our clinic, do you take any sleeping pills or Tylenol PM? The Benadryl is a risk factor. It's anticholinergic, and while it may not, cause delirium right Johnny on the spot, if somebody becomes dehydrated or febrile, it's going to be a predisposition. So, the medication profile is important. In the right-hand column, you can see issues about alcohol excess, and more importantly, or equally importantly, I should say, alcohol withdrawal. So I actually experienced this as when I was first learning how to be a geriatrician in North Carolina. I was called to the emergency room, and a gentleman had an acute confusional state, and I had to call his wife, who was visiting family in California, and husband was left by himself with a little touch of memory disorder, but he could get around on his own. And I said, is there any issues about his taking his medications? And she says, no, he's got all his medicines. I said, well, what about anything else? Does he drink alcohol? And she says, oh yeah, I hid the vodka bottle on him so he wouldn't have any martinis when I was away, because he kind of gets goofy. And so sure enough, he had alcohol withdrawal syndrome as a reason for his delirium. The other factors that play into delirium are sensory impairment. That's why when I do nursing home rounds, I always bring a package of alcohol wipes and get everybody's glasses cleaned up, so they can see properly. It's amazing how many greasy lenses there are in long-term care facilities. We also look in the ears, because hearing impairment can also be a risk factor, for delirium. Bed rest and prolonged bed rest is a connection with delirium, as is restraint and any devices, so catheters, whether they be blood or urinary catheters, and of course pain. So unresolved pain can be a strong precipitant of delirium. So there's a mnemonic that was developed out of St. Louis University, and their GWEP, which is kind of our sister GWEP in geriatric education, and they talk about delirium being associated with these monikers of drugs, electrolytes, lack of drugs, so that's withdrawal, and of course that also includes alcohol. Infection is a big one in terms of inducing delirium. Reduced sensory, intracranial changes, so usually intracranial pressure, stroke, hydrocephalus, urinary retention, fecal retention, so urine and bowel blockages can cause delirium, as well as heart attacks and pulmonary emboli and or infections of the lung. So you can break it down in another way of, first you have to rule out and make sure the patient is not septic if they have delirium. I always check a pulse oximeter to make sure that they're not low on oxygen. Maybe in the hospital or emergency room setting, there's a blood gas to see if they're retaining CO2, which more typical in a COPD patient. Electrolyte disorders, that's why we always get a chemistry, and then also understanding if there's withdrawal. So sometimes a drug profile or urine drug screen is obtained. And then in terms of medication, there's always post-op sedation that can lead to delirium. The anticholinergics that I mentioned, things like diphenhydramine or Benadryl. And then there's just plain old idiopathic. We don't know what's causing the delirium. So the question is, where does delirium occur? And so you can see it occurs an awful lot in the ICU. And if you go down the list here, in hospice and palliative care. On hospitalization, of the 33% that present with or have delirium or acquire delirium, half of those are at the admission and usually through the emergency room. And then the other half are acquired during the hospitalization. And just a classic example, when I had started off doing consultative rounds at our affiliated hospital, I was noticing a lot of the hospitalists were using Benadryl as a sleeper. And I said, yeah, it's benign, it's no big deal. They're not going to fall, because if we give them lorazepam and stuff and then 2 days into the hospitalization, patient starts developing delirium. They go, geriatric consult, they have delirium. So, kind of pointed out to them, if they hadn't started the Benadryl in the beginning, probably wouldn't have had delirium. Hard to tell, but there is a connection. So there are consequences of developing delirium. So that's why we want to try to prevent it. There's both short and long-term sequelae. The worst, obviously, is death, related to delirium. So people in the intensive care unit have anywhere from 2- to 4-fold increase in death. Similar, although a little bit smaller odds ratios for general medical wards. And kind of the interesting thing is that the risk of death is not necessarily in the hospital. It's like when you get discharged. And so, it's just like this other marker that I have mentioned previously. If you leave the hospital with low albumin, you've got a 50% chance as an older adult of not making it the following year. So there are these predictors that we need to be mindful of and have meaningful conversations with the older adults and their family members to talk about their risks. Do you have your advanced care planning in place? Do you have your POLST, P-O-L-S-T, in place? So these can be triggers for an important conversation, particularly when people have delirium. So that's part of the post-hospital discharge planning, post nursing home discharge planning, or even nursing home entry planning. The other point that I want to make is that, death and disability can be associated with delirium. There's a 2-fold or greater risk of a cognitive decline of some sort. Sometimes these cognitive declines, like after you get a CABG, for your heart bypass surgery, there might be a 3 to 6 month cognitive lapse, where people and they say, I'm not as sharp, I can't remember. And then it slowly comes back. But in terms of delirium-related cognitive decline, that may be a permanent dip or decline in cognition that could lead to frank dementia or Alzheimer's. Not going to spend a whole lot of time on this, just, suffice it to say that when people get delirium, it costs a lot and it's causes a lot of morbidity and mortality. It also leads to institutionalization, and people's quality of life just is not the same. It's a real hit on cognitive and functional abilities. In fact, even without delirium, people who go into the hospital, 40, if they're over the age of 65, 40% of them come out of the hospital with some sort of functional disability. So hospitalization is a benchmark for transitions in functional trajectories of older adults. So how do we figure out if somebody has delirium or not? So studies show that about half of the delirium, when it exists, is not recognized or documented by healthcare workers. There was an interesting study that showed how hospitalists and hospital-based doctors prescribed Haldol and these other antipsychotics for newly admitted hospital patients, and 90% of the time they never documented why they were giving the medication. So it's a huge gap in electronic medical record documentation. So the basic form or clinical tool that we use is called the CAM, Confusion Assessment Method. You have to have both of the top two, number one, number two elements, and then you have to have either 3 or 4 to make the diagnosis with 95% or more sensitivity. So basically, there's acute change. It's fluctuating. It's like a roller coaster, I always tell family members. And perhaps the most important thing is it's inattentiveness, right? They jump from one thought to another. They'll talk about how nice it is outside, and then they'll say, "And did you see that bug on the wall?" And they'll just shift. There's no logical sequence between that. So or they just lose interest. Oftentimes I'll ask them to count from 100 backwards, and they'll start at 199, and then they go 92, and then they start thinking about it, and then they just kind of like either drift off or go to another topic. So that's inattentiveness, as well as disorganized thinking, which is the second point. In terms of altered consciousnness, we're talking about a range from comatose to, jumping up and down on the bed, it's agitated. So that's the full range, that spectrum. If the confusion assessment method is not convenient and you want something Johnny on the spot, you can just ask the patient to state the months of the years backwards and then state the day of the week. So as related to one of the questions, the vast majority of delirium is associated with the hypoactive version, and 25% are what we consider classic delirium, which is agitation and behavioral changes. The hypoactive version is typically the person just lying in bed, doesn't want to be bothered, right? So the nurse's aide or somebody brings in a food tray and they say, "Oh, just take that away, I'm not interested." That nurse's aide probably may not recognize that that's a form of delirium and may not report that to the nurse. And so it's important for us to increase the direct care health workforce to understand these little cues, these little nuggets of information that might help them communicate changes in older adult or patient status. The other issue that I wanted to make or point is that hypoactive delirium sometimes may be confused or may not be confused with new onset depression and or dementia. And the hyperactive version has to often be, not frequently, but should be distinguished between mania and bipolar or agitation related to depression. But as I always think about this differential diagnosis, my psychiatry colleagues always tell me that, nope, it's delirium. So even though we try to say, oh, maybe it's bipolar, and they go, no, it's delirium. So I've yet to see the diagnosis where somebody's suspected of having delirium has a different diagnosis. This is kind of interesting. I've not used this personally, but you can see that this is a severity scale. And so it's called the CAM-S, obviously for Confusion Assessment Method -severity. And it's scored on up to a 19-point scale. It has 10 different questions, and you can track this in terms of following somebody with delirium. So, you're not going to solve delirium in lickety-split. It's going to occur over a period of days to weeks. And so you can use this form to see where the trajectory is going. So if that score starts to get lower over time, it shows that you're making progress with your delirium intervention. And this might be a good quality intervention tool if you were to implement something in the hospital or in the nursing home and somebody develops delirium and you have a new program. And we'll talk about some of the programs that are evidence-based for addressing delirium. This would be a good tool for quality improvement. So firstly, you want to ask somebody who is manifesting delirium. Again, hypoactive, just lying in bed, not doing much, listless, disinterested, and or somebody who's like, there's bugs on the wall kind of situation. So you want to figure out when this all started. You definitely want to figure out if they have a fever or they've got symptoms of dyspnea, shortness of breath, chest pain, mentioning pain previously. Has there been any change in the medication profile within days to weeks? Because sometimes changes in medications don't show up for maybe a week or two after you've changed the medication. And this is particularly true with longstanding people that have been on antidepressants, for example. In fact, there was another case that I had where a family got split up because of one of the spouses visiting family and the other one staying home. And the spouse that stayed home forgot to take his amitriptyline, which is not a great medicine in older adults to begin with, but he had amitriptyline withdrawal, and that's why he wound up in the emergency room. And then also just to query, again, the story I told earlier about the daily martini or 2 martinis, that sometimes older adults imbibe in their retirement. And I always tell people that 1 martini is worth 2. And, in terms of the metabolism. So even though somebody may not sound like they're overindulging in alcohol, that 1 martini may actually be equivalent to 2. You may have heard my comment or story about my father-in-law who's passed away, but he really enjoyed his martinis, and he would always have 2. And when he got his Parkinson's medications, both myself and his sons advised him that he should cut back. He says, interesting, the doctor said the same thing. So he says, and he dutifully decreased his daily alcohol to 1 martini, but he switched bottles. He went from a red cap to a blue cap, and it turned out he went from a 75 proof to 150 proof. So he was getting a double martini in 1 glass, so as that works. Great guy though. Let me just skip here. Next, in terms of the physical exam, obviously vital signs are important. Pulse oximetry. So we want to know temperature. If somebody has a rapid heart rate, that's going to tell you that something is going on. You want to look at the eyes. I can't tell you how many times I've had medical students and medical trainees who just don't look in people's eyes. They didn't recognize the fact that one pupil is larger than the other. That's called anisocoria. And even more importantly, they never look at the back of the eyes, and they never look for papilledema. So I'm always very mindful when we have a patient coming in with headaches and high blood pressure. I said, look at the back of the eyes, make sure they don't have papilledema. And you can see them fumbling around with a ophthalmoscope, and it's clear in our medical education these days we're not really emphasizing their skills enough, because everybody relies upon, of course, a CAT scan or an MRI scan. But nonetheless, that's something that you want to take a look at to see if there's also neurologic asymmetry. So is there facial droop, slurred speech, all the things that we equate with stroke. The other thing that we do is extend the hands outstretched. I always say, be like Superman or Superwoman. And for 1 minute, you have to hold it and watch for liver, asterixis. And so it's a slow, steady beating of the hands or wrists that's associated with hyperammonemia, which is often associated with liver failure. The last points there, the battle sign, the raccoon's eyes, bruises, would indicate trauma, either from a fall or elder abuse. And so the battle sign is the purplish behind the ears. The raccoon sign is purplishness or ecchymoses under the eyes. Those are associated with basilar skull fractures, and those are not good things. In terms of laboratory tests, you really don't have to jump over to get a head CT or an MRI, and I think doctors are gaining a little better appreciation for this, that when people show up in the emergency room, they don't have to get them over to the MRI scan. I think it's in part because there's been so much overuse of MRI scans that people are heeding these recommendations of using tests wisely. It's part of the American College of Physicians program to use tests wisely, or choose wisely is the program's name. You want to look at the CBC, make sure there's no elevated white blood count, no changes in hemoglobin. A precipitous drop in hemoglobin sometimes can induce delirium. Electrolytes are huge: low sodium, low calcium, high calcium, changes in potassium, less so changes in magnesium. Urine analysis is important for defining potential urosepsis or urinary bladder infection. Urine toxicology, as mentioned earlier, for drug screens. Alcohol tests is also important for the blood. Blood culture. Just had a patient recently who no temperature, diabetic, but looked like he had a foot infection. We got blood cultures, and sure enough, they were positive. So, you always have to be aware of very subtle changes. And then plus or minus whether you want to get a chest x-ray or EKG. I always tell people that the chest x-ray actually may be normal in the beginning of pneumonia in the older adult, so don't always rely upon that for the diagnosis. So in terms of management, it may be the most straightforward thing to do is change the medication. So if they were on a tapering dose of a antidepressant, you may have to go a little bit up on that dose. Usually they talk about 10 to 25% changes as you transition from medication dosing, particularly people that have had long-term medications. If you identify or suspect an infection, you treat it, obviously with antibiotics or antivirals. Try to manage fluids, and more typically it's you're hydrating rather than water restricting. But people that have what we call salt retaining states of heart failure, liver failure, and kidney failure, you may not want to push fluids as much as somebody who doesn't have those organ failure situations. Obviously, treating hypoxia with oxygen or mask with oxygen. If somebody is a COPDer, you worry about hypercapnia, so you're very careful with monitoring how much oxygen you give them. You bump them up from 2 liters to 3 liters, all of a sudden they start retaining CO2 and they develop hypoactive delirium. Obviously, hypotension needs to be addressed, and severe anemia. One of the questions that's come up is that, well, okay, if you have end of life, hospice patient who's got delirium based upon anemia, do you do a blood transfusion? And the answer is it depends as to what the remaining life expectancy is and whether it's causing any discomfort that can't be managed by medication. Another point that people often overlook is fecal retention. Having obstipation or constipation and doing a rectal exam to see if you need to disimpact somebody is really critical, particularly since one study showed that up to 40% of delirium was caused by obstipation or fecal impaction in older adults. And then finally, and sometimes empirically, we have to treat pain. A lot of times demented patients who have acute confusional states can't tell you that they're having pain. They just can't put 2 and 2 together because of their expressive aphasia. And so you end up empirically treating the pain. Typically, you start off with round-the-clock Tylenol. In terms of management behaviors, you always want to think non-pharmacologically first, especially while you're making the diagnosis. You don't want to jump right to medications. So the axiom of go with the flow is important. Had a patient in our geriatric unit once who came out and declared himself king of the world. And I said, Jose, this is good. Let's go find your castle. So we kind of walked him around, and he said, oh, I think we found it. It's like, we're joking. And he got back to his castle, and he continued as king of the world. So that was going with the flow. But then also reassurance, that I'm gonna go get your daughter, and we're gonna make sure we hold court here, and kind of go with the delusion. And you don't want to really grab people, like, if you're going to redirect them, you just kind of cut them off at the pass, if you will, but don't grab people, because if they have delirium, they're going to they're confused, and they're going to react defensively, and a lot of times they may lash out. So try to avoid physical contact as much as possible, even though it says to reassure. A hand on the shoulder may not be the best way to go. It's more voice reassurance. Make sure that the lights are not, if they're in the hospital, they're lying back, and they've got that fluorescent light shining right down on them. Turn that off. And so just being mindful of the glare and the lighting. Address any neurosensory deprivation. So if they need glasses, make sure they get the glasses, and the glass eyewear is clean. If they have a hearing aid, maybe it needs a battery. Maybe it needs the cerumen impacted in the tube cleaned out. So just good hearing aid hygiene, if you will. And then also reorienting the person. So having clocks telling what the date was. Today's Tuesday, and Tuesday afternoon, and so forth. And tomorrow's Valentine's Day, or something like that. In terms of the medication interventions, you can use low-dose antipsychotics, particularly if there's delusions or hallucinations. And again, this is more directed towards the hyperactive version of delirium. You typically don't want to prescribe these medications for somebody that has hypoactive delirium, because it'll make it worse, and it may convert them from a reversible to an irreversible delirium. Typically, Haldol or risperidone are used. Some people like to use risperidone because of its alleged reduced incidence of Parkinson's-like syndromes or tardive dyskinesia, extrapyramidal symptoms, and they're both pretty similar, quite honestly. Most of the studies don't really indicate one being superior over the other in terms of side effects, profile side effects. And I think it's really, really important that if these medications are prescribed, that you warn the patient and the family, even if they're delirious. You have to warn them, we're going to give you this medication, and you might get stiffness and Parkinson's-like symptoms from it. And you have to let them know it may not be reversible. So that's why using these medications is really, you have to make sure the person's more of a danger to themselves than others, and that's what you have to document before you start using these medications. And then secondly, if you do initiate the medication, you have to have a schedule of de-escalation. I can't tell you how many nursing home patients I admitted with the hospitalist saying Haldol 0.5 milligrams every 12 hours and PRN. Well, guess what? The government, and Medicare, I should say, figured out that doctors were taking the easy way out, and they were just saying PRN so that nobody bothers them in the middle of the night for that agitated patient. And it's not allowed anymore. You can't write PRN orders for antipsychotics. So it has to be scheduled. And part of the problem is that then once you get it scheduled, there's no de-escalation plan. So once the delirium is resolved, months afterwards, the person, is still on the antipsychotic for really no good reason. I just want to mention down here, there's the olanzapine, the quetiapine, and the ziprasidone. And those, I use quetiapine quite a bit more, just because you can use very, very low doses, and it's a little bit more sedating. And quite honestly, once you've decided to go with these medications, it's all about sedation, so that's the problem, is that, you're just simply reducing the behavioral agitation by sedating them. And then that comes with issues like aspiration, falls, and all the other things that you want to avoid too. So you can see there's a conundrum. So if you can at all avoid these medications by having a bedside sitter, family member, reassurance, and all the other things we talked about non-pharmacologically, those are way, way more preferred. I don't have any experience with pivaneserin for Parkinson's disease related psychosis, probably also associated with Lewy body dementia. So I really can't comment. I just want to make you aware that that medication is available. And then last on the list is lorazepam. And there's 2 points that I want to make. Lorazepam usually is reserved for alcohol withdrawal syndrome. It's not used as a first-line therapy for delirium. And there's no evidence that the combination of Haldol and lorazepam is any better than Haldol alone. And in fact, if your intention is to sedate people, the more medicines you add to sedate, the more likely they will be sedated and have complications as a result of that. So again, it's always a trade-off between trying to reduce the behavior, again, driven by whether they're a problem, in terms of safety for themselves or others, like, if they're tearing out IVs or, heading down the hallway and, causing problems and hitting people. Those are the types of behaviors that you want to treat chemically. When these are chemical restraints. But if it's just an inconvenience because somebody has to sit in there and they don't like to hear them screaming, not a good reason to be using these, right? So we need a little different mindset about, how to manage this. And some hospitals actually have a delirium ward, where this behavior can play itself out over time. And we'll talk a little bit about the recovery from delirium here in a minute. All right, so if medications and or restraints, and hopefully nobody's using restraints anymore, my God, this is medieval times that they put restraints on people, but it does happen periodically, particularly in the intensive care unit, because again, people are pulling out their endotracheal tube and you don't want that to happen. But on the general medical ward or in long-term care, restraints should not be used. So if you do use them though, you have to monitor how effective they are. You have to document every 2 hours, for example, or every hour, their use, and then you also indicate at what point you're going to stop using them. So it's all part of that reassessment and documentation. I already gave you the kind of the disconnect, with this big study that they did and found that a lot of hospitalists were treating delirium with medications, but they never documented it in the chart. In some of the big cities that would be considered malpractice. So you really do need to document. And then the important point is to have a de-escalation plan. Additional management interventions will include scheduled toileting. And that's actually a good thing for somebody that's more bedbound. You want to have scheduled toileting anyways for the older adult, and that helps prevent delirium. Already gave you my rant on avoiding restraints. It's important to engage family and sitters, and actually, tell them not to use agitated, strong language, not to reprimand. Try to avoid touch, just more reassurance, verbal reassurance. And then people that are bedbound and have hypoactive delirium, it's so important to try and get them turned around so they don't develop decubitus ulcers. In terms of sleep hygiene, again, don't give them Benadryl, avoid sedatives. Ambien doesn't work very good. In fact, Ambien within the first 30 minutes of somebody taking that, if they're an older adult, are going to be equivalent to a drunk sailor, and they have a high probability of falling. And they only gain 30 minutes of sleep from that anyways. Already mentioned about reorientation and the importance of family education and training. Yeah, so the recovery it's a tough one. It could take weeks. It could take months. It may even take a year. So the problem is that if the longer it takes for the delirium to resolve, the higher the likelihood that the person is not going to be with us within the next 6 to 12 months. And that's a conversation that needs to be had with the family members to say, they just go in and out of this. And it's important actually as a healthcare provider to understand that cyclical nature, that roller coaster effect, because I can't tell you how many times my geriatric fellows and I went to the nursing home to find somebody in florid delirium. And in the medical note says in the morning, the hospitalist says, patient doing better, clear of mind, and I should say clear of mind and spirit, but they misidentified the resolution of the delirium. They just took the opportunity when the person was lucid to say, "Oh, you're good. You can leave the hospital now," not really understanding the true aspects of the chronologic manifestations of delirium. So it's important in care transitions, these handoffs, to know what the baseline cognition is. And so if somebody is, like I call blabbering away, if that's their baseline, then good enough, and that needs to be conveyed. But if they were blabbering away normally, and then all of a sudden they're just totally quiet and not saying anything, that's delirium, right? So that needs to be identified, comparing behaviors from one point to another point. I can't emphasize enough about the documentation of stating that they have delirium. Study I did a long time ago, unpublished, looked at 149 consecutive charts out of a community hospital emergency room and then hospital notes. And there was only, one person that said acute mental status change, and there was no mention of delirium whatsoever in either the emergency room notes or in the hospital notes. So again, it's just not on people's minds. And then there's some research that shows that intensive therapy and skilled nursing does not change the outcome of delirium, which is kind of disappointing. But the key point is that if you can avoid multiple hospital transitions to nursing home to home, that's to be encouraged, is to reduce the number of changes that people have. So in prevention, there's a program fairly well known called HELP. That's the Hospital Elder Life Program, and it has a multi-point intervention that involves cognition, importantly hydration. So one of our local partners with our geriatric program is Edgewood Group, and they offer refreshments throughout the day in their assisted living facilities, and have been able to reduce urinary tract infections and delirium as a result of that. And it's pretty impressive, that just in the community setting, that you can do these small things to help prevent cognitive declines like delirium. Ramping up hearing, so that's why in our clinic we're always looking in the ears, trying to make sure we get either see china or see beeswax, so whatever it is, we try to address that hearing loss. Same thing with the vision. So we always screen people when they come into the clinic. Same thing in the nursing home, because visual changes can make a big difference. And then, believe it or not, mobility. If people are inactive and are chair bound or bed bound, they are so highly disposed to delirium. So sometimes we have to do a little tough love and get them up and moving around, particularly for people that like to lie in bed, because what happens is you get atelectasis, and it increases the probability of hypoxia. And then you add a little bit of sleep apnea at night, and you've just triggered delirium, and then maybe plus or minus aspiration. So there's this whole cascade that we can help prevent if we just properly address mobility. So this HELP program reduces delirium significantly, odd ratio of 0.47, which is pretty good. Well, I guess, being a geriatrician, I have to comment that geriatric consults help reduce delirium. And so particularly in a collaborative program with geriatricians and orthopedic surgeons, it reduces delirium by 30 to 40% postoperatively. And this is very reproducible. It came out of the University of Rochester many years ago. And I'm shocked that this program as a model of care has not been replicated across the country. And in part, it's probably due to the fact that there's a shortage of geriatricians. I'm just in the midst of renewing our geriatric grant, and looked at the data. And the American Geriatric Society said that we need, between North Dakota and South Dakota, we need almost 150 geriatricians. And I think we have about 12, and half of those are retired. So so there you go. We just don't have the manpower. So in terms of preoperatively, some people think that melatonin might be a preventive medication intervention. I know there was a study out of UC San Francisco that looked at gabapentin as a prevention for delirium, and it didn't work. But melatonin, maybe. So it doesn't hurt, right? The only point that I would make is to make sure that the melatonin doesn't exceed 5 milligrams nightly. A lot of people think more is better, and you find people on doses of 10, 20 milligrams, and it's like, kind of we're getting into, I don't know if I would call it toxic range, but it's not going to help. All right, so I want to wrap up here with a discussion about this case report and see what you guys think about this. So we got an 84-year-old female comes into the clinic and expresses a loss of appetite and weight loss ever since her husband died 2 months ago. The primary care doctor prescribes a low-dose SSRI called Remeron because she believes the patient to be depressed. And she heard a wonderful geriatric presentation that suggested that Remeron could be a potential appetite stimulant. Takes the medication. 1 week later, the patient's taken to the emergency room with new onset confusion. So based upon what you've learned today, what would be your first next step if you're the emergency room doctor or nurse? And so you can unmute yourself and offer what you would do next. And I would suggest that you think about what clinical tool you would want to use, or you can just go into the chat box. I think I can see what's going on there. So I'm just going to play the devil's advocate here and say, if I don't get any responses here, we're going to assume the patient, oh, there you go. Thank you, Mabel. So labs and CAM-S. Yeah, good for you. And probably the confusion assessment method, firstly. So the CAM-S has 10 points. You want to focus on those first 4 points. So you want to do the CAM and then establish whether they have delirium. And so we don't know from this history, but probably dime to a dozen, this person does have delirium based upon a fluctuating course, sudden onset, and so forth. And so the other 2 points are to look at the laboratory tests, and so that's good. And I think that the in this particular case, what you'll find is that the person had a low serum sodium. And so it's well known that about 8 to 10% of patients that get started on SSRIs who are over the age of 65 experience SIDH, syndrome of inappropriate ADH secretion, and they become hyponatremic or low salt, and that causes confusion. And so that's exactly what this patient had. So thank you for offering those thoughts and how to work this patient up. So let's see if I can. Nope. There we go. Yeah, so the confusion assessment test was positive in this patient, and she had low serum sodium. So to summarize here, I just want to mention that delirium is often under-recognized, so we have to have a high vigilance. And most of the cases are hypoactive versions of delirium. Age, chronic conditions are risk factors for delirium. We always want to look for the reversible causes, and I think everybody that submitted those questions or answers about rule out infection, is good, because that's what you want to establish first. In fact, some hospitals have protocols that you can't start antipsychotics for delirium until you've ruled out metabolic or infectious etiologies for the confusional state. We know that preventive measures work. So hydration is probably one of the biggest on the list. Reorientation and mobility are important. Try to avoid delirium-inducing medications. You've probably heard me say Benadryl many, many times. So I'm going to also mention that prednisone can cause delirium, and you have to warn people that if they're on high-dose prednisone that they may get a little loopy because it is anticholinergic. And then finally, all possibilities here is to emphasize non-pharmacologic management, as we discussed, about making the person comfortable, reassuring them, go with the flow, and try to avoid harsh physical contact.